goes on behind the scenes with lean pharmacy and nursing, physicians, microbiology, what's done every day to kind of support appropriate antimicrobial use. So we'll talk a little bit about common antibiotics. We'll do a microbiology review and some terms. And obviously the meat of the potatoes of the thing will be to talk about antibiotic stewardship, how the program works, what happens on a daily basis, why we need one, the problem with resistance, and how you guys can help on a daily basis, since you're not frontline guys. We always be patients. So first of all, what antimicrobials are. Basically, they're agents that kill microorganisms or stop their arrest of growth. So they're grouped primarily against the pathogens they work on. So antibiotics obviously for bacteria, and antifungal for fungi, antibiotics for viruses, and antiprotozoals are protozoa. So mostly we'll talk about antibiotics here, but antimicrobial stewardship deals with all of these. So antibiotics specifically are classified by one of these three things: either spectrum activity, so the pathogens they work on. So narrow spectrum agents work against only a few organisms, and broad spectrum agents work against a lot of different pathogens. So you'll see how that plays into a variety of infections that we treat. So the mode of action is another area that classified by is basically the way the drugs actually work and how they produce their killing effect or their growth arresting effect. And then finally, the effect of having bacteria. Are they bacteriostatic, which means that they suppress growth while the immune system does the rest of the work? Or do they have bactericidal, which acidality means that they kill the bacteria outright? So again, it's bactericidal as a bacteriostatic also guides which agent we choose in which situation. So immunocompromised patients, obviously, septic patients who are with a suppressed immune system, we use bactericidal agents, preferably over bacteriostatic agents. So again, we'll go through those. So this is a very busy slide, but basically, when we choose an antibiotic, empirically, which what empirically means is if somebody walks into the emergency department, or somebody walks into an office, and we suspect we have an infection, they have a white count, fever, we choose an antibiotic based on where we think the infection is, the source of the infection, and based on what pathogens it covers. So basically, you can see the broad spectrum, the difference between broad spectrum agents and narrow spectrum agents. So something like penicillin only works against, basically a gram-positive streptococcus and some gram-negative, but only a few bugs. Something like amoxicillin clavulanate, which is augmentin, would be a broad spectrum agent because it covers a wide variety of gram-negative pathogens and also a wide variety of gram-positive agents. So the big drug that we all love and use every single day is penicillin tazobactam, which is Zosyn, the blue one. I don't know if you can see that's the blue one that's right here. So that one covers almost everything. So that's why we always see everybody, sepsis, they get Zosyn, because mostly you cover everything. There's a little tiny little hole. Again, this is not all inclusive. It doesn't have every single bacteria in here, but most common things are there. Meropenem is there as well. Again, very broad spectrum. Vancomycin, that most people think is broad spectrum, is actually not broad spectrum at all. It covers only gram-positive pathogen. It has no gram-negative activity whatsoever. So when drugs are being administered for severe infections, that's something to think about in terms of what's given first. So we always want to give the broad spectrum agent, especially in sickest patients, to give the broad spectrum agent first, and then give vancomycin second, because it adds on expanded gram-positive coverage for MRSA, really, is generally added. So your Zosyn should always be infused first, if that's, that helps thinking about it. And obviously there's some agents that are very specific, such as Zithromax, that is only used for really typical pathogens and pneumonia, such as Legionella and Mycoplasma and things like that. So again, this is just a guide to let you know that there's a difference between all of these. So now, as far as classification by mode of action, some antibiotics work differently. So beta-lactams, which is the most commonly used agent class everywhere, is really because of its safety and because of their efficacy. And they work on the cell wall, and those are your penicillins, which means amoxicillin, ampicillin, augmentin, Zosyn. These are all will be unison. These will all be in here. These are all penicillins. Cephalosporins are, ceftriaxones, most commonly you see that cefazolin, and you do a lot of preoperative stuff that would be there. And carbapenems would be meropenem, and it's the oldest here, the penem we used to have before. So, those are the monobactam is really a strenum, which is restricted really for usually gram-negative coverage. It's very specific use. Vancomycin again is a soluble agent as well.
ER. Your attention, please. Code stroke. ER. Your
And
attention, please. Code stroke. ER.
another drug that's used usually a lot of fluoroquinolones, which work in cytosol and DNA gyrase, and that's ciprofloxacin. And again, and the rest of them are also work inside the cell as well in machinery, DNA machinery use, ribosomal machinery, 50S, some unit of ribosome, and 30S, so it's tetracycline, doxycycline, and then macrolides, we talked about Zithromax, clindamycin, Zylox, which also a restricted agent. But, so immunoglycosides, a lot less used, a lot more we see preoperatively, those who practice in that area. But, those are your gentamicin, tobramycin, and amikacin, those agents. Again, used a lot less often nowadays because of toxicity associated with that. Usually renal toxicity is what we worry about. Now, in terms of effective bacteria, so when I was talking about static and cidal, so this kind of tells you, static effect, the ones that kind of arrest growth, and the immune system has to do arrest, and cidal is actually kill bacteria. So those are the ones that, beta-lactams that we talked about, the most commonly used, vancomycin is there. And then on the other side is really the cidal ones that you don't see as often, again, because they're mostly used outpatient or step-down therapy would go from maybe to oral therapy, those are the drugs we usually use. Again, the sickest patients are probably not going to get those. So just a little refresher on microbiology. Normally what happens is when a specimen is collected in a lab, the first thing that's done is to determine what type of bacteria it is. So it's something called a gram stain. So the gram stain is basically the bacteria has died and it either turns purple or violet, which is your gram positives, and or pink or red would be your gram negatives. So there's some of the more common gram negatives are down there, E. coli, Pseudomonas, really associated with pathogens, hospital pathogen really. And then gram positives are streptococcus and staph. Again, so it helps us because when initially the lab runs this result, and let's say we have somebody on broad spectrum therapy of vancomycin and zosyn is the most common. Keep going back to that. And the gram stain, let's say in the urine comes back, or the blood comes back with a gram negative rod. So it tells us right away that we can tailor therapy already. We can stop the vancomycin because it's a gram negative. So gram negative vancomycin, as I said, doesn't cover gram negative, so we can get rid of that. We're not worried about it. We're not worried about a gram positive. Or vice versa. Let's say somebody's on zosyn and you have a gram positive growing in a gram stain. Then you may consider, depending on the situation, is adding vancomycin for expanded gram-positive coverage in addition to what zosyn already covers. So it is very useful because antimicrobial stewardship can start right then and there, and the gram stain is usually available fairly quickly. They're done very quickly, so you can start right away trying to tailor your therapy there. So these are the most common pathogens that we see here. So now, how do we actually get when we get sensitivities, what we call sensitivities? How does that actually work? So traditionally, after the gram stain is done, then organism is plated, and after that, there's growth on a plate with media, with growth media. It's put into this that dilution plate, which is a microscan system that we use microscan dilution. That's what Northwell uses as well. And the way that's done is basically serial dilution, which is you have a set amount of organism that gets put into these wells, and then increasing amount of antibiotic, decreased concentration of antibiotic. So that down there, drawing down there, represents the serial dilution, how that would go into the wells. So 0.25 and increasing by 0.5, 1, 2, 4, and so forth and so on. And that's increasing concentration of antibiotic. So your MIC is a concentration, the first concentration at which you see no growth or no turbidity. So in this case, it's 2, is in this example. So the machine, the microscan machine it's an automatic thing that plate is put into a machine, it runs it, and it's able to spit out basically what the MIC, what that pathogen is, and that identifies the pathogen and what the MIC is. I'm simplifying it, obviously. Pretty can do a lot better job than this, but basically that's the gist of it. So that's how we get those MIC values that you see in Meditech. So now the breakpoint is what tells us, it's set by different organizations, and it tells us where that sensitivity is. So I'll show you on the next slide, and that's how we know if an antibiotic is going to be effective or not. So basically, if the MIC is below the breakpoint, it's considered susceptible, or at the breakpoint it's considered susceptible, and you have, using standard doses of antibiotics, you'll have high probability of clinical success. Intermediate is not as great, so you're getting above the breakpoint, and you're getting close to resistant, and again, you would need higher concentrations, or you would have to treat infections that are easier to attain at certain concentrations. So something like meningitis, if you have something in the intermediate breakpoint, you probably should not be using that drug because it's that much harder for it to get into the CSF. And resistant, obviously, is when you fall on the other side of it and you are not going to probably get there. And the only time you're going to be using these drugs that are resistant is when you have nothing else left. And multi-drug resistant pathogens, sometimes you're forced to use resistant antibiotics, and the pathogen is resistant to it, but use it at higher doses and in combinations. So basically, going back to this example, so let's say if the breakpoint in this example was 1, then this pathogen would be considered resistant because it's growth on that MIC of 1. If the MIC got cut off, the breakpoint was 2, then it would be considered sensitive. So basically, that's the basic gist of it, is how we're able to tell if somebody is resistant and sensitive. So this is all standardized, and CLSI, the Clinical Laboratory Institutes of Standard Institutes, sets these MICs, these MIC breakpoints, based on evaluation of population data. So they see that there's shifts in resistance, they adjust the breakpoints. So most recently, let's say the breakpoints for fluoroquinolones were adjusted to reflect that there's increased resistance rates in our population to both. So for gram-negatives and pseudomonas, it was actually brought down. So even lower concentrations of drug would be considered resistant. So again, it all depends on the distribution. So and it's evaluated once yearly, and they update it in this document called M100. It's actually available online for free. If you Google a CLSI M100, it comes right up. You can search and you can get the breakpoints. So what a breakpoint for each drug are. So another thing I wanted to mention with breakpoints is I'll talk about it later as well. Is it's very difficult to compare breakpoints of different drugs against each other and different organisms against each other, because drugs work differently and organisms are a little different in terms of the way they're, the way drugs affect them. So, and I'll go into it when I show you an example. So again, now just going through quickly, just where we see pathogens. So when we do, again, empirically, we target somebody who's, let's say, with community-acquired pneumonia. So we know they're going to have a strep, a Haemophilus influenza, and atypical pathogens. And when the antibiotics we're going to use empirically are things that are going to be treating those pathogens. So that's why you see Osefin and Zithromax for community-acquired pneumonias, because the Osefin will cover Streptococcus and Haemophilus, and then atypicals are usually covered by the Zithromax. So that's just an example. But for UTIs, again, Antibacteriaceae or E. coli are basically gram-negative pathogens, and Osefin is a lot of times you see used empirically for UTIs until we get sensitivities, because again it targets those bugs. And I'm not going to obviously go through all this, but this goes into when we're verifying orders, when a pharmacy is looking at when a physician is ordering something. We look at this, we look at the patient's prior history, whether they've come here before, whether it was isolating the urine or blood or or sputum. We look at their allergies. We look at obviously what there's another source of infection suspected, and that's how empirically how sick they are, obviously as well. So if they're neutropenic, then again we use a cidal agent. So all this dictates how we pick antibiotics empirically. So now to go into antibiotics really in the history. So before we had antibiotics, there was basically no way to treat infections. Once they were discovered, it was basically a miracle that saved a lot of lives. And now the procedures we do, everything we do in modern medicine basically relies on antibiotics. So routine surgical procedures that require preoperative prophylaxis, such as intra-abdominal procedures, would not be possible because of the risk of post-op infections that is very common if you don't give patients post-op prophylaxis. Neonatal care, or your newborn gets what's called eyes and eyes, that's they contain inflammation in there. So again, for infection. Transplantation patients, obviously, really compromised. Chemotherapy we were able to do because patients get neutropenic usually require either prophylactic antibiotics or if they have neutropenic fever, they need basically treatment for possible infection. So none of that would be possible if we didn't have these. The first antibiotic that really was mass-produced was penicillin, discovered by Alexander Fleming in the 1920s, and really perfected and started to really be made mass in about World War II. So again, saved a lot of lives, especially in the war, from mass injuries, so there's just a lot of benefit there. And again, you can see this is just from 1900 to 2000s. So there's milestones there, and you see penicillin first used in the 1940s, when it was mass produced. Obviously contributed to the fall of mortality from infectious diseases, in addition to other population health things such as vaccination and chlorination of water. But again, penicillin is one of those things that did make this possible. So actually, Alexander Fleming was quoted as saying this in the New York Times article in 1945, an interview that microbes are educated to resist penicillin.